Hey, welcome back. How's everybody doing? I know this get a little bit long, but this is a lot of information in this week, so thank you for bearing with me. This one, we're going to talk about Medicare, Medicaid, and all of those things that go with it. Now, when you get into reimbursement methods as a second-year student, you're going to go into this information again. But one thing you have to remember, in the spring, you're going to do professional practice experience and go out and, be in a healthcare facility. So it's important to know or have heard a little bit about all of these things, because you're going to hear it when you go out in the spring. It's going to make a little bit more sense. So to this one, we're going to look at government-funded healthcare, which is Medicare, Medicaid, CHIP, that kind of thing, okay? So Medicare, as I told you before, was created in 1965, and it is funded partly by payroll taxes. Your employee pays 1.45%, and your employer pays 1.45%. So your employer pays into that for you too. FICA pays for Medicare Part A, which is hospital care insurance. Hospital insurance helps cover when you're an inpatient, hospital outpatient, skilled nursing or rehab care. Now, this is misleading. It says long-term care facility. It will not pay for nursing home. Medicare Part A will pay skilled care in a long-term care facility for 20 days. Now, if it's a different kind of long-term care facility that's all hospital-based, it's a different story. So don't let that mislead you. Medicare Part A will also pay for end-of-life or hospice care. In Medicare Part A, just like any other insurance, the patient does have to pay a deductible, but most Americans pay no premium for Part A. Others who have never paid in on FICA, they can buy Part A coverage. But when you get your Social Security check, they don't deduct for Medicare Part A. What happened with Medicare, and there is a video that I put in week 12 of this course that I really want you to watch. It's the history kind of reimbursement, and it does a wonderful job summarizing it. But when Medicare started, it was like, oh my gosh, the lid went off the checkbook. Because when it started in 1964, if that hospital billed $1,000 for patient stays, government wrote them a check for $1,000. Well, guess what happened? It's called a moral hazard, and more Medicare patients were being admitted, and Medicare costs were being up. I mean, it was like having a blank check. So the government realized they had to do something. So what they did was they instituted lots of legislations before PPS. They instituted legislation called utilization review. And what utilization review did was say, oh, you're not going to go to the hospital unless it's medically necessary. So you hired utilization review coordinators, and they'd go, checklist, check. Yep, they have to be admitted. It really didn't do a lot of good. It was a lot of paper exercise. So then they did the PPS system. PPS means that under Part A, if I go into the hospital with a heart attack and I'm 67 years old and I have Medicare and I have no complications except the heart attack, I don't go into heart failure, nothing else happens, the hospital is going to get paid a set dollar amount for me with a heart attack. The pay is predetermined. It falls into a algorithm, a system, which we'll talk about in week 12. But that pay is predetermined, so that hospital knows for that Medicare patient what they're going to get. Regardless of what service they provide, this is what they're going to get. So that rate depends on what's called the patient's diagnosed related group, or DRG. So the DRG for a heart attack is X amount of dollars. DRG for a fractured hip is X amount of dollars. DRG for a stroke is X amount of dollars. So that reflects that information's chart at time of discharge. So each type of facility, if you get Medicare Part A, you're in the PPS system. Now Part B is different. Part B is medical insurance. So that's your outpatient costs. That's what the doctor charges you, and the person who reads your x-rays charges you, and all of those outpatient issues. So it'll pay for doctor services, outpatient care, home health, some preventative services, not all. Well, for example, it doesn't pay for eyeglasses, and other medical services. Now, under Medicare Part B, when you're Medicare eligible, you do have to pay a premium. So you buy this insurance, you have to pay it, and you pay a deductible for that. So I bought Part B, just like my regular insurance now. I pay a premium, I pay a deductible. There's also Medicare Part C. Those are called Medicare Advantage plans. These are offered by private companies that are approved by Medicare. So under an Advantage plan, they're called Medicare Advantage. You don't see them called Part C very often, but they provide the services for all of Part A and Part B and some Part D, which we'll get to. They can also have where you pay extra for things such as vision insurance, hearing examinations and hearing aids, and dental services. Patient pays a premium and deductible. Now, what's nice about this, it's more comprehensive than Part A and Part B because it covers more. But guess what? You also pay a little bit more. Part C options also include you can be in a health maintenance organization, you can be in a PPO, you can be in a private fee-for-service plan with a provider, or a special needs plans. Now, I want to make sure that you read the transcripts that go along with this lecture, okay, because it gives you more information. Part D then is prescription drug coverage. Part A doesn't cover meds unless you're a hospital inpatient. Part B does not cover meds. Part C, you have to have Part D. So this was created in 2003. It's voluntary enrollment. It's provided by the insurance company or any other private company approved by Medicare. Patients pay a premium and a deductible, and at a certain point, they may have to pay up to 50% of drug costs themselves, called donut holes. So, for example, my mother has a Medicare Advantage plan, and that has the medication part, Part D. My mother's medications cost her a lot of money every year because she has diabetes, and we all have heard reports on what they charge for costs for medications. Her Part D will pay drugs up to a certain part, but then when she gets in to a certain point where she's exceeded that, she goes into a donut hole, and she has to pay them 50% of her drug cost. That hurts. It really hurts. The advantage is her medication providers, her pharmacists work with her, so they get those most expensive meds ordered first. So when she gets into that donut hole, hopefully that 50% cost would be some of her less expensive drugs. Medicaid. They pay for medical costs of people with limited income and resources. Again, you've heard it before. It's federal and state. Some people on Medicare also qualify for Medicaid. They may not have money on Medicaid to pay their premiums under Part B or their deductible, so they could be eligible for both. These are also all funded by taxpayers. So they're administered at the state level, and then states formulate and administer a plan that's subject to regulations. So for example, in Iowa, you may have heard for the last few years how Iowa Medicaid went to managed care organizations. There were 3 of those. They were called MCOs. 1 left. It hasn't worked as well as what Iowa would thought, but it is still in a state of flux. But a lot of healthcare facilities and agencies that depended on Medicaid dollars became very frustrated just trying to get paid through an MCO. Lots of issues with it. If you want to do a little research, it's a great topic for a future report. Medicaid, each state has different eligibility requirements. So you may be eligible in Wisconsin, but not in Minnesota, not in Iowa. But under that, they have to provide payments for hospitals for physician services. They have to provide payments to pharmacy, dental, and eye care. And they must not provide payments for abortions under regs. Now think about it. Medicaid will pay for that. The issue is finding someone to provide that service. Medicaid traditionally has very set dollars on what they will and will not pay for. So you may live in an area and you may not be able to find any dentist that accepts Medicaid for reimbursement. So even if you have Medicaid, where are you going to go? What are you going to do? Same way with eye care. You might find very few providers who provide that eye care. So you really have to know where the services are that you can get. Medicaid programs can have different names in different states. And again, this talks about funding. CHIP is low-cost health insurance for children and families that earn too much money to qualify for Medicaid, but they don't earn enough money to buy private health insurance. CHIP is a wonderful program, and that's just my opinion. You can think about it all you want. But there are a lot of families who what they call the working poor. They work just enough, they can't get help, but they don't make enough to buy health insurance. And it just gets to be a bigger and bigger hole. So with CHIP, children are insured health insurance coverage, and it has been wonderful. When my children were little, there was no such thing as CHIP. We were the working poor. We didn't qualify for Medicaid, but we couldn't buy health insurance. So my children had absolutely no health insurance and at all for the first several years of their life. Medicaid and CHIP can work together. They have a range of benefits, including, it's listed here, doctor visits, emergency care, hospital care, etc. MACRA. MACRA is a term, it's relatively new. Okay, it's the Medicare Access and CHIP Reauthorization Act of 2015. When CHIP first started, it was funded, the funding was limited, so what MACRA did was they extended CHIP's program, and CHIP is still here because it keeps getting extended. But then it established a physician payment schedule that would allow for the rate of inflation, so what they paid physicians would keep up with inflation and changing times. But basically what MACRA sought to do was to pay for the value and quality of care rather than the quantity. So this way, what they wanted the physicians to do was participate more in reporting quality standards. And if they did that, then they would get payment incentives. So say, for example, a quality standard is vaccinations for children. And they might report on the number of vaccinations, the number of children vaccinated in their area or under their care. They report that. There could be a payment incentive, means you get increased reimbursement. Now, what you report on is defined by the government, but if you participate, it does help. They used a merit-based incentive program, and this is called MIPS. So when you go out in PP1, you might hear people talk about MACRA, and you might hear them talk about MIPS, but this is what it is. Fraud and abuse, we talked about in an earlier unit. Fraud is the intentional falsification of information to deceive Medicare and Medicaid. I mean, it's flat out, I know I'm doing wrong, I don't care, I'm going to cheat it. Abuse occurs when doctors or suppliers don't follow good practices, so they do unnecessary cost, improper payments. Services aren't medically necessary. So abuse, you can get into trouble too. So unnecessary cost, an example, ordering lab tests that you don't need, or ordering lab tests that were just done and you could have looked at that lab test previously. You got paid wrong because you coded it wrong. So not on purpose, but you just did, you got paid wrong. They contract with an agency called a RAC, which is a recovery audit contractor. And what the contractor does is looks for unnecessary cost, improper payment, and services that aren't medically necessary. And if they find them, they will take your payment that you received away. And then the healthcare provider has to, or services, they have to appeal that RAC to prove that this didn't happen. Healthcare facilities today spend a lot of time appealing RAC information of services that may or may not have been done the way that they thought they should be done. Okay, I'm going to stop here and we'll go to the next part.